Imagine a patient's heart is failing. I mean, it's beating in this chaotic, totally fatal rhythm. Your absolute first instinct, like logically and emotionally, is to give them a drug to fix that rhythm, right? To stabilize the heart.
Right, of course, that's human nature.
But if you do that, clinical data shows you will likely kill them. Welcome to the counterintuitive, incredibly high-stakes world of medical diagnosis.
Yeah, it's wild. The human body, it rarely follows our intuitive logic. We want things to be linear. We want a symptom to point directly to a single, easily fixable problem. But, clinical medicine is this interconnected web where treating one symptom blindly can cause a catastrophic failure somewhere else.
And navigating that exact web is the topic of today's deep dive. We're exploring a medical text that is essentially a survival guide for that chaos. It's the Yale-G First Aid, Crush USMLE Step 2 CK and Step 3, the 4th edition by Dr. Yale Gong.
It's a heavy hitter.
Oh, absolutely. And our mission today is to extract the most high-yield, critical clinical knowledge from this text. We're translating these really dense medical protocols into the clear, actionable insights you need to understand the human machine.
The philosophy of this source material is really what makes it so valuable. Because whether you're a medical student prepping for the boards or a young clinical professional on rounds or, just an insanely curious self-taught learner, you can't rely on reading exhaustive historical paragraphs about a disease when a patient is actively crashing.
Yeah, no one has time for a history lesson in the ER.
Exactly. So the text is built entirely around the essentials of diagnosis and these high-yield questions, or HYQs. It really trains you to realize that knowing what to look for, like the specific biomarker or the exact clinical presentation, is just as important as knowing why it matters.
Okay, let's unpack this, because I want to see how that philosophy actually works in practice. To do that, let's start with one of the most common but also trickiest clinical presentations you can encounter, which is severe abdominal pain.
Oh, yeah. The classic puzzle.
It feels like a total guessing game. A patient comes in clutching their stomach, and it's like trying to figure out which pipe is leaking in a flooded house. How do you possibly know where to look when everything is already underwater?
The flooded house is actually a really helpful analogy, especially since the organs in the abdomen are just so tightly packed together.
Right.
But the text cuts through that noise by providing a very clear scientific differentiation for 3 major biliary and pancreatic emergencies.
Right.
Instead of guessing, you look for highly specific structural clues. So let's look at acute pancreatitis first.
The presentation for this one is incredibly specific. It's a sharp epigastric pain, meaning it's right in the upper central abdomen, but it radiates straight through to the back. And it usually hits the patient right after a really big meal.
Yeah, and the anatomy perfectly explains that symptom. The pancreas is retroperitoneal, meaning it sits deep in the back of the abdominal cavity, behind the stomach and intestines. So when it gets severely inflamed, the pain naturally radiates backward toward the spine. But the text also highlights these visual clues that tell you when this inflammation is escalated into a really severe necrotizing crisis.
Yes. I remember reading about Cullen's sign and Gray Turner's sign. These are like wild skin discolorations.
They're very ominous signs of internal destruction. In severe acute pancreatitis, the digestive enzymes produced by the pancreas essentially become activated way too early while they're still inside the organ.
Wow.
Yeah, so the pancreas literally begins to digest itself and eventually digests the surrounding blood vessels. This causes hemoperitoneum, basically internal bleeding. The blood tracks all the way through the tissue planes to the surface of the skin.
It's terrifying.
It is. So Cullen's sign is this blue bruised discoloration pulled right around the umbilicus, the belly button. Gray Turner's sign is that exact same blue discoloration, but showing up on the flanks, along the sides of the abdomen.
So seeing those means the damage is already extensive. But obviously, you don't just diagnose based on a bruise, you run lab tests. The text explicitly points out that you look for elevated serum lipase and amylase. But I found this distinction really helpful. Lipase is sort of the hero here. It is way more sensitive and specific for acute pancreatitis than amylase.
Biochemistry is key there. Amylase is an enzyme that helps break down carbohydrates, but the thing is, it's produced by your salivary glands and your intestines, as well as your pancreas.
Oh, right. So a high amylase level could literally just be a salivary gland issue.
Exactly. Lipase, on the other hand, is an enzyme that breaks down fats, and it is almost exclusively tied to the pancreas. If serum lipase is elevated, you have your culprit. And once you establish that diagnosis, the text immediately pivots to Ranson's criteria.
This is a scoring system to predict mortality, right? It looks at things upon admission, like if the patient is over 55, their white blood cell count being over 16,000, high glucose, and high LDH. Which I actually had to stop and look up LDH.
Yeah, lactate dehydrogenase.
Right, which is an enzyme inside your cells. If it's high in the blood, it basically means cells are just bursting open and dying.
That is the exact mechanism. And the text instructs you to check these patients again at 48 hours for different criteria, like a drop in calcium or a drop in hematocrit.
Hematocrit being the concentration of red blood cells.
Yeah.
But wait, why are we checking all these systemic markers if the problem is just a localized inflamed pancreas?
Because the entire body is reacting to the localized destruction. Acute pancreatitis triggers a massive systemic inflammatory response. Fluid shifts out of the blood vessels and into the tissues, which is why your hematocrit might look totally abnormal. The inflammatory cascade pulls calcium out of the blood, leading to dangerous drops.
Oh, wow.
Yeah, Ranson's criteria aren't just measuring the pancreas, they're measuring how badly the rest of your physiological systems are failing in response to it. If a patient hits 7 or 8 of those criteria, the mortality rate approaches 100%.
That is just terrifying. So returning to the flooded house analogy, that's the pancreas. What if the leaky pipe is the gallbladder?
Then you are dealing with acute cholecystitis. This occurs when a gallstone completely blocks the cystic duct, preventing the gallbladder from draining. The location of the pain shifts entirely. Instead of being central and radiating to the back, it's sharply localized to the right upper quadrant, or RUQ, and the hallmark physical exam finding here is Murphy's sign.
Which is when you push your fingers up under the patient's right rib cage and ask them to take a deep breath, right? As they inhale, their diaphragm pushes the inflamed gallbladder down directly into your fingers, and the sudden, sharp pain makes them just abruptly stop breathing.
Right, a sudden inspiratory arrest. It's a highly reliable clinical test. But to confirm it, the sequence of imaging is crucial. The text maps it out very rigidly. The absolute best initial tool is an ultrasound.
Makes sense.
Yeah, it uses sound waves, it's non-invasive, and it's excellent at visualizing physical stones and seeing if the walls of the gallbladder are thickened from the inflammation.
But the text also provides a backup plan, which is cool. Like, if the ultrasound is equivocal, if the imaging is murky, and you aren't completely sure, you move to a HID scan or coloscintigraphy.
The mechanism of the HID scan is a brilliant functional test. Ultrasound only shows anatomy, but HID shows function. You inject a radioactive tracer into the patient's bloodstream. The liver naturally filters this tracer out and secretes it into the bile, which then flows down the biliary tree.
All right.
In a healthy person, that tracer flows straight into the gallbladder. But if a gallstone is blocking the cystic duct, the tracer will bypass the gallbladder entirely and just flow directly into the intestines. You are literally watching the physical blockage in real time.
It just proves the obstruction is there. Now, the third condition in this abdominal trio is acute cholangitis, which sounds similar, but the text treats it as a massive immediate threat.
It is arguably the most dangerous of the three. Cholangitis is an infection of the entire biliary tree. It usually happens when a stone slips out of the gallbladder and blocks the common bile duct further down. The stagnant bile becomes this perfect breeding ground for bacteria from the gut, which then back up directly into the liver.
Bad news.
Very bad. The text defines this using the Charcot triad.
Right. Upper quadrant pain, jaundice, and fever with chills.
Exactly.
Yeah.
The moment you see those 3 alarm bells need to ring. The jaundice occurs because bilirubin is backing up into the blood. The fever and chills mean the infection is severe. The infected bile is trapped under high pressure, essentially pouring bacteria straight into the bloodstream.
So antibiotics alone won't fix it.
No, antibiotics alone will not save this patient. You have to physically decompress the system.
And the intervention recommended by the text is an ERCP, endoscopic retrograde cholangiopancreatography, which is really just a long way of saying to snake a camera down your throat, past your stomach, into the intestines, and then go backward up into the bile duct to pull the stone out and drain the pus.
Right. It serves as both the definitive diagnosis and the life-saving treatment all at once.
The through line here is just undeniable. When someone comes in with severe abdominal pain, the exact millimeter location of that pain, noticing blue skin discolorations, and choosing precisely between an ultrasound, a HID scan, or an ERCP, it literally dictates whether the patient lives or dies.
You are diagnosing a structural failure by observing its specific cascading effects. And, that concept of cascading systemic failure transitions us perfectly from localized plumbing issues to the central pump itself. Let's look at ischemic heart disease and acute coronary syndrome, or ACS.
Right. So acute coronary syndrome fundamentally means the heart muscle is starving for oxygen because a coronary artery is blocked by a clot or a plaque. The classic symptom is that crushing chest pain radiating to the left arm. But I got really confused reading the cardiac section regarding the blood tests used to track the heart attack. The text discusses the timeline of cardiac biomarkers. These are the proteins that heart muscle cells spill into the bloodstream as they die, right?
Yes, and the timing of those spills provides a molecular timeline of the patient's trauma. When a patient arrives with chest pain, an ECG can confirm an ST elevation myocardial infarction, or STEMI. The ST elevation on the monitor physically represents the electrical baseline of the heart shifting because the muscle tissue is actively dying all the way through its wall. But the lab tests tell you exactly when the event started.
The text lays this out so clearly. Myoglobin is the first marker to rise in the blood within 1 to 4 hours, but it's not specific to the heart. It just means muscle damage is happening somewhere. Then CKMB rises in 4 to 6 hours, and troponin rises in 2 to 4 hours. Now, troponin is the gold standard because it is hyper-specific to cardiac muscle. But here is where my confusion comes in.
Okay.
The text states that if a patient survives a massive heart attack and then 3 days later gets chest pain again while still in the hospital, troponin is completely useless for detecting if they are having a second new heart attack. Why did the gold standard suddenly become useless?
You're touching on the fundamental difference between sensitivity and half-life. Troponin is incredibly sensitive for detecting the initial injury. However, once those heart cells burst and release troponin, it stays elevated in the bloodstream for 7 to 10 days.
Oh, so if you draw blood on day 3 or 4, the troponin levels are still going to be sky high from the first heart attack. It can't show you a new spike.
Precisely. It cannot distinguish a reinfarction. This is where CKMB becomes vital. CKMB also spikes during the initial heart attack, but its half-life is much shorter. It clears out of the blood in about 3 days.
Okay, I see.
Therefore, if a patient complains of new chest pain on day 4 and their CKMB levels are suddenly elevated again, you have definitive proof of a brand new infarction. The first wave cleared out, so a new wave means a new blockage.
You use the short-lived protein as a real-time alarm system. It's a very practical application of biochemistry. So when that alarm rings and the patient is actively having a STEMI, what are the critical treatment steps the text outlines?
The guiding principle is time is muscle. The immediate medical therapy involves administering oxygen, aspirin, and beta-1 blockers as quickly as possible.
Right.
The aspirin stops platelets from clumping, preventing the blood clot from growing. The beta blockers slow the heart rate down, which decreases the heart's demand for the oxygen it isn't getting. But the ultimate definitive goal is primary PCI.
Percutaneous coronary intervention.
Yeah.
Angioplasty.
Exactly. A cardiologist threads a catheter into the blocked artery, inflates a microscopic balloon to crush the plaque, and leaves a stent behind to hold the artery open. The text stresses a strict clinical deadline for this. The goal is to have the artery open within 90 minutes of the patient's first medical contact.
90 minutes from walking through the doors to having a wire inside your heart. That's fast. But this brings me back to the scenario we opened the show with. A patient is having a heart attack, and their heart rhythm deteriorates into ventricular tachycardia or ventricular fibrillation. This chaotic rhythm is the #1 cause of death in these patients. Instinct screams at you to give them an antiarrhythmic drug to prevent the fatal rhythm.
Right.
But the text aggressively states you must never use prophylactic antiarrhythmic medications. How does a drug designed to stop an arrhythmia end up increasing mortality?
It comes down to understanding the cellular environment of a dying heart. Antiarrhythmic drugs work by altering the flow of sodium or potassium ions across cell membranes to control the electrical firing rate. But in an ischemic heart, a heart actively starving for oxygen, the cells have no ATP, no cellular energy to run their ion pumps. The electrical grid is already incredibly unstable and depolarized.
So the normal rules of pharmacology just don't apply.
Not at all. If you pump antiarrhythmic drugs into a heart whose ion channels are already failing, you further block those channels. You effectively add fuel to the fire, freezing the electrical grid entirely and triggering the exact fatal circuits you were trying to prevent.
Wow.
Yeah. The current protocol requires you to wait. You never use them prophylactically. You only intervene with electrical cardioversion or defibrillation if the fatal rhythm actually occurs.
Instinct says one thing, but understanding the cellular mechanism demands the exact opposite. It's the difference between saving a life and ending it. And that tension between instinct and protocol is just as pronounced when we move to the final major area of the text, which is toxicology and extreme physical trauma.
We are shifting from internal systemic failures to massive external threats that completely overweigh the body's natural defenses. Emergency toxicology requires rapid, inflexible memory. You don't have time to hypothesize. You have to know the specific biochemical antidote to the specific toxin.
Reading through the toxicology section felt like a high-stakes matching game. For an acetaminophen or Tylenol overdose, the required antidote is acetylcysteine. An overdose of heparin, the blood thinner used in hospitals, requires protamine to physically bind and neutralize it. And an overdose of warfarin, another common blood thinner, requires vitamin K or fresh frozen plasma.
The warfarin example perfectly illustrates the theme of time management in medicine. Warfarin works by blocking the liver's ability to use vitamin K to manufacture clotting factors. If a patient takes too much and starts bleeding, giving them vitamin K provides the raw material needed to restart production. But synthesizing new proteins takes time.
Which doesn't help if they are bleeding out right in front of you.
Exactly why the text specifies fresh frozen plasma for severe cases. Fresh frozen plasma already contains the finished, active clotting factors. It provides instant reversal, while the vitamin K takes hours to work.
Speaking of immediate reactions, I have to ask you about red man syndrome. The text brings this up in relation to vancomycin, which is a very potent, heavy-duty antibiotic. But the text explicitly clarifies that this intense reaction is not an allergy.
This is a vital diagnostic distinction. If you administer vancomycin too quickly through an IV, the patient's face, neck, and upper torso will flush bright red, and they will become intensely itchy. It mimics a severe allergic reaction perfectly.
Totally.
However, a true allergy is an immune system error driven by IgE antibodies. Red man syndrome is a direct physical toxic effect. The vancomycin molecules physically cause the mast cells in the patient's skin to burst open, dumping massive amounts of histamine directly into tissue.
So because it's not an immune system allergy, the treatment isn't to ban the drug from the patient's chart forever. You just slow down the IV drip rate and administer an antihistamine to mop up the spill.
Right. If you mistakenly label them as allergic to vancomycin, you deprive them of a highly effective, potentially life-saving antibiotic for the rest of their life, all based on a mechanical error in infusion speed.
That is such a crucial distinction. Okay, so that covers the chemical trauma. But the text also dives deep into extreme physical trauma, specifically a condition called rhabdomyolysis. It happens after seizures, massive surgeries, or crush injuries, like if someone's leg is pinned under a collapsed wall.
Rhabdomyolysis is a terrifying physiological cascade. The word breaks down to rhabdo, meaning striated skeletal muscle, myo, for muscle, and lysis for breakdown. When a large volume of muscle tissue is crushed, the cell walls tear open and dump their internal contents straight into the bloodstream.
And the most dangerous component of that cellular debris is a protein called myoglobin.
Myoglobin is the oxygen-carrying pigment inside muscle cells, very similar in structure to hemoglobin in red blood cells. The problem is that myoglobin is highly toxic to the kidneys. As the circulatory system tries to filter this massive dump of muscle pigment, the myoglobin gets trapped inside the microscopic renal tubules.
Oh.
Yeah. It forms solid physical casts that plug up the filtration system, effectively choking the kidneys to death and causing acute tubular necrosis.
The text gives this fascinating diagnostic tip for rhabdo that feels like a trick question. It states that if you test the patient's urine with a standard dipstick, it will show up aggressively positive for blood. But when you take that exact same urine sample and look at it under a microscope, there are absolutely zero red blood cells visible.
It's a classic paradox.
How can it be positive for blood but have no blood cells?
Because the chemical pad on the dipstick is designed to detect the heme molecule. It automatically assumes that heme equals hemoglobin from a red blood cell. The chemical test cannot distinguish between the hemoglobin of a bleeding urinary tract and the myoglobin that just poured out of crushed leg muscles.
Wow.
So the dipstick lights up positive, but the microscope reveals the structural truth. There are no intact red blood cells to be found. It's pure muscle pigment. That specific discrepancy between the dipstick and the microscope is the absolute hallmark of rhabdomyolysis.
The false positive is actually the definitive diagnosis. That is wild. So once you realize the kidneys are filling with myoglobin sludge, how do you save them?
You have to aggressively flush the renal tubules before the myoglobin can settle and form solid casts. The text outlines 3 simultaneous steps. First, massive intravenous saline hydration. You expand the blood volume to force fluid through the kidneys. Second, you administer mannitol.
Mannitol is a sugar alcohol, correct? How does a sugar help flush the kidneys?
It acts as an osmotic diuretic. Mannitol is filtered into the renal tubules, but the kidneys cannot reabsorb it back into the blood. Because it stays in the tubes, osmotic pressure forces water to follow it. It pulls massive amounts of water into the urine, creating a high-pressure, fast-moving flow that essentially power washes the myoglobin out before it can stick.
That's incredibly clever. And the third step is administering sodium bicarbonate, basically intravenous baking soda. Why are we altering their pH?
Two critical reasons. First, when muscle cells burst, they also dump massive amounts of intracellular potassium into the blood, which can trigger a fatal cardiac arrhythmia. Bicarbonate helps shift that potassium back into the surviving cells. Second, myoglobin precipitates, meaning it turns from a liquid into a solid kidney-choking sludge much faster in an acidic environment.
Ah, I see where this is going.
Right. By giving bicarbonate, you alkalize the urine. You raise its pH so the myoglobin remains dissolved in liquid form, allowing the mannitol flush to actually push it out of the body.
You are utilizing the physical principles of osmosis and pH balance to reverse a devastating crush injury. Looking back over this entire deep dive, that seems to be the unifying message of this textbook. It forces the medical mind to move past panic and utilize precise pattern recognition. You locate the specific biomarkers, you understand the underlying cellular chemistry, and you follow the orderly steps to save the organ.
It is the crucial difference between merely reacting to a symptom and anticipating a systemic cascade. Mastering that mindset, knowing how a failure in one system will inevitably stress another, is what elevates clinical practice.
Since the explicit focus of this book is high-yield questions, we really can't wrap up without a quick test. As requested by the structure of the text itself, let's run a clinical scenario directly from the book's HYQs to reinforce everything we've unpacked today. Are you ready?
Hit me. Let's hear the presentation.
Okay, you at home listen closely too. Here is the scenario. A 50-year-old man is brought to the ER experiencing a fever, sharp epigastric pain that is radiating to his back, and nausea for the past 4 hours after eating a heavy dinner. His chart notes a history of chronic right upper quadrant pain and jaundice. His current lab tests show elevated serum lipase, amylase, alkaline phosphatase, and direct bilirubin.
Those are very classic overlapping markers.
Based on our discussion today, what is the most likely diagnosis, and what is the best next step to physically remove the underlying obstruction? I'll give you a second to think about the cascade. Okay, let me break it down. Based on the sharp epigastric pain radiating to the back and the highly specific elevated lipase, he definitely has acute pancreatitis. But the history of right upper quadrant pain, the jaundice, and the elevated bilirubin point to the root cause. He has acute cholangitis and pancreatitis because a gallstone has slipped down and is blocking the common bile duct, affecting both organs, and the best next step to physically remove that obstruction.
The patient requires an immediate ERCP, endoscopic retrograde cholangiopancreatography, to clear the duct, decompress the system, and save both the pancreas and the liver.
Perfect. Before we go, I want to leave you with a final thought to mull over. Throughout this deep dive, whether we were talking about a single impacted gallstone backing up and destroying the pancreas while simultaneously infecting the liver, or a simple crush injury to a leg releasing a muscle pigment that completely shuts down the kidneys on the opposite side of the body,
it forces you to confront the sheer fragility and interconnectedness of human biology. We tend to study organs in isolation, separated into neat chapters of a textbook, but your body is a constantly communicating, highly pressurized ecosystem. A leak in one pipe doesn't just flood a single room, it shorts out the electrical grid of the entire house. It challenges you to stop looking at symptoms as isolated events and start respecting the incredible, terrifying domino effect of the human machine.
The X-ray might not show the damage, but if you know how to read the systemic pressure, you can always find the leak. Thanks for taking this deep dive with us.